Okay. So we did pituitary, hypothalamus. We're moving down now to the adrenal glands. Again, keep in mind, too much or too little. What happens? Um, so we're going to go over disorders of the medulla, the cortex. The medulla is only one, very easy to remember. And the cortex, we obviously cortisol, aldosterone, and our androgens. Those are the only three hormones that are in the adrenal cortex. Only three ones we'll talk about. So our objectives for today. Quick review. Cortex on the outer end, medulla is in the middle. We have our two glands on either side on top of the kidneys. And there they are, triangular shape. This is what it looks like in real. Okay, about 5 grams. But the cortex is about 80% of that 5 grams. So the cortex is very, very, very much more of the adrenal gland than the medulla is. Blood supply via adrenal arteries and venous collection via the suprarenal veins. This is where you got to start knowing things. So make sure you know the glomerulosa produces aldosterone. The fasciculata produces your glucocorticoids, your cortisol. And the zona reticularis makes your androgens. You have to know this one because some things will affect certain zones versus the other ones. The medulla is just your catecholamines, epi and norepi. Okay, that's all you gotta worry about. So here's a good way to study if you want a picture of it and the different zones and what they produce. Here's the blood supply going through those different zones. We start off making the aldosterone. Then as the blood supply comes down, we get cortisol in that zone. And then finally, the reticularis zone where the DHEA and the androgens are. And then as you get into the medulla, this is where your catecholamines are. And remember, one of the big stimulus for this catecholamine release is cortisol. Because cortisol is made right there, and it travels down. Why is cortisol going up? In what situations would cortisol rise? Stress. Don't you want epi and norepi to come out when you're in a period of stressful environment? Yes, so that cortisol, as it's in this blood supply, when it comes down and it gets into the medulla, it's going to stimulate also to make more epi and norepi because it means that we're having a stress response and we need more of that stuff coming out. So we have short-term stress responses, which are healthy, and we get the more prolonged stress responses, which are not the healthy ones. Short-term stress response, increased heart rate. Just think fight or flight. You got scared, something happened, you moved on and left, and then everything went away. We know what happens with fight or flight, so all those things should make sense now. The more prolonged stress. Now this cortisol, aldosterone are being secreted constantly in higher volumes due to the constant stress. So the long-term stress response, retention of sodium and water by the kidneys. Aldosterone's going up, production's going up, so aldosterone goes up, so that changes that. Increased blood volume and blood pressure. Again, we're retaining more volume, blood pressure goes up. Proteins and fats are converted to glucose or broken down for energy. Okay, some catabolism here. Increased blood sugar, suppression of your immune system. So you start getting sick easier with these prolonged stresses. Okay, that's why some of you will start getting sick in a few months, in a month, just from the constant stress of being in peace. It's just normal response. I'm kidding, you'll be fine. Okay, so long-term stress deals with those problems. Short-term, fight or flight, it's okay. So remember, your glucocorticoids are going to have effect on glucose. Cortisol is the primary glucocorticoid. Your mineralocorticoids, minerals, it's going to be aldosterone because it affects your sodium and your potassium. So that's your aldosterone. And then your sex hormones are just your androgens. Here's our HPA axis again. Make sure you know the feedbacks and what cortisol, the negative feedbacks for cortisol and ACTH. So glucocorticoid excess. Now we're producing too much cortisol. Okay? Causes protein and carbohydrate metabolism changes, distribution of adipose tissue. Remember we talked about the moon face, the buffalo hump with excess cortisol, which is called Cushing's. redistribution of fat, electrolyte abnormalities, immune system, gastric secretion goes up, so you get more acid. More acid in the stomach can lead to what disease we talked about? Gastric ulcers, GERD, okay, all that excess acid, okay, with prolonged stress. That's the link between stress and ulcers in the stomach. Constant stress, constant acidic environment in the stomach can lead to ulcers. Brain function problems, erythropoiesis, and obviously an inflammatory response. Metabolic effects of these excess glucocorticoids: stimulates gluconeogenesis, interferes with insulin, causing hyperglycemia. So that's why I get hyperglycemia with excess cortisol in Cushing's. Loss of protein from the skin, muscle, and bone. That's why you get the striae on those bellies of these patients with the Cushing's. Skin gets degraded in thinner stretches. You get those really bad stretch marks, the striae. Atrophied muscles. Remember I talked about these patients, big bellies and small arms and legs, because they get atrophy. And osteoporosis due to all that excess glucose, the cortisol. Okay, mobilization of fatty acids from adipose tissue gives you the moon face. Inhibition of your inflammatory, cellular, and humoral immune responses leads to that immune response being impaired, allowing you to get sick easier, delayed healing. Here is the stress, stimulates gastric pepsin and hydrochloric acid, therefore increases your risk of peptic ulcers, which we mentioned, and also this emotional lability. Okay, so this is what cortisol does. Decreases phospholipase A2. When you decrease that, you don't make any arachidonic acid because cortisol is going to inhibit the enzyme that converts it. If you don't have it, you don't get prostaglandins and you don't get leukotrienes because of the excess cortisol. So cortisol lowers the formation of prostaglandins and leukotrienes. Why are prostaglandins important, especially in the stomach? Helps with the mucosal barrier. Those prostaglandins are important with that mucosal barrier. If your cortisol is excess and you're reducing the amount of prostaglandins, your mucosal barrier is diminished. All this excess acid tips the scales, and you can potentially get those peptic ulcers. Okay, moving on to mineralocorticoids, your aldosterone. Chief hormone, maintains electrolyte balance, sodium reabsorption with water, and it's going to secrete potassium into the urine. So keep that in mind whenever we talk about excess aldosterone or lack of aldosterone. Androgens, DHEA, DHEAS are the two main ones, have masculinizing and anabolic effects, which is why, like in women, when they have PCOS, they have a problem with the androgens and they get hirsutism, they get the hair on the face, because of the masculinizing, the anabolic effects of the DHEA. Adrenal medulla, 3 catecholamines, mainly epi, norepi, a little bit of dopamines found here as well. Response to sympathetic stimulation. Again, these are sympathetic nervous system effects. This should be repeat by now, I hope. Okay, all your alphas and your betas. You'll get a lot of that with Dr. Wood when you get to cardiac. So they're coming. But again, the goal, raise blood pressure, raise heart rate, raise glucose, dilate the bronchioles. Again, fight or flight. You're going to be running away from something. You got to have good airways, good blood supply to feed all your muscles. So you can look at it, this is a way to look at as far as like hyperfunction versus hypofunction. And as we go through the different ones, you'll see how they all fit together. So we're talking about the adrenal medulla first. The only one that's in the adrenal medulla we have to worry about is a pheochromocytoma. It is a tumor in the adrenal medulla. Usually it's a benign tumor, but it's a space-occupying tumor. So it's compressing the adrenal medulla. So it's always going to be squirting out epi and norepi. Very uncommon, less than 0.1% of patients. You may see it on rotations though, because I think I remember one student did see a feel at one point during rotations, so they do pop up. Both sexes are going to be affected. Fourth or fifth decade of life can happen in children, but for the most part, it's going to be adults. So basically, there's your pheochromocytoma. It's that tumor space-occupying lesion in the adrenal medulla and causes problems. So this is your adrenal pheochromocytoma. There are other things that can happen as well, this extra adrenal pheochromocytoma. Remember, we have those sympathetic side chains, those ganglia, where all the sympathetic system comes right off the spine, off the spinal cord. Okay, those areas can also be affected. But what I want you to know is basically the adrenal one. Just know it can happen other places, but the adrenal pheochromocytoma is the more important one. Okay, neoplasms of the chromaffin cell. Remember, the chromaffin cell is what stores and holds your epi and norepi. 90% are benign, like I said. Majority of them are going to be benign tumors. They can metastasize to liver, lung, bone, or the brain, though. Okay? So basically, what happens when they get compressed or irritated, they're going to dump an enormous amount of catecholamines in your blood system. Are you having a fight or flight response at that time? No. Are you going to have one in about 2 seconds? Yes. Artificially, because this tumor causes that stuff to dump out. Oops, sorry. So we get severe elevated blood pressure for 2 reasons. 1, alpha receptor vasoconstriction. Okay, what is going to cause the alpha constriction? Which one, epi or norepi? Norepi. Remember, norepi has a preferential love for the alphas. It can attach to both, but it goes to the alphas more. So norepi comes out, it's going to go to the alphas and constrict them. When you increase the peripheral vascular resistance, what happens to your blood pressure? Goes up. Now, that's the alphas. We also have beta receptors to worry about because we have epinephrine floating around as well. Okay, so those beta 1 receptors mediated increases in cardiac output and renin release. What's that going to do to your blood pressure? Increase it. So now you have 2 methods for increasing your blood pressure based off of this pheochromocytoma. Okay, and that's where they get these really high spikes in blood pressures because of this unopposed alpha and beta stimulation. Okay, diagnosis is very important because they can be fatal. During surgery or if you're pregnant and you have a feel, they can cause problems from there, yes?
As far as like emotionally, do they present with anxiety, stuff like that?
They can, but it's not going to be constant. It's going to come and go. Whenever the tumor gets compressed and those things gets released, then they'll have those symptoms. But when that's normal, then they'll be okay. Okay, so you really want to check for these things if you think they have it. So clinical manifestations vary in intensity, and obviously they're going to be episodic or paroxysmal. Okay, whenever you see paroxysmal, it means episodic. It comes and goes, like paroxysmal atrial fibrillation. It comes and goes. Okay, so they can occur several times per week, once a month, potentially 25 times per day. Okay, so having this very, very high pressure can be a big problem. They can last up to 15 minutes or for days, okay, and become more frequent as time passes. So the longer you have this, the more spikes you're going to get in your blood pressure, and they're going to happen more frequently as time goes on. They're often precipitated by compressing the tumor. Okay, if they bend over to pick up something, they're bending over, they can compress the tumor, causing catecholamines to be dumped out. So bending, lifting, defecations here, deep abdominal palpation, those can all cause a compression of this tumor, dumps all the catecholamines, and you get a blood pressure spike. Okay, those with persistently secreting tumors will have more sustained blood pressure. What do you think would lead you to believe that there may be another reason for this patient's blood pressure not coming down? Because if they have normal blood pressure, if I give you lisinopril or any of those medicines, your blood pressure is going to drop. In these cases, they're not going to. Because the reason for the blood pressure being high has nothing to do with anything else. It's just that these catecholamines squirt out, and they cause these massive rises in blood pressure. And as long as these catecholamines are still being released, you're not going to be able to control it with medication. So when you give them medicine, their blood pressure is not going to come down. And whenever you have a patient who's refractory to blood pressure medications, you have to start looking at other reasons. Okay, a pheochromocytoma is one. What is another reason for elevated blood pressure that's not responding to medicine we learned about already? Where would it be? Because you're close. What? Pre-renal. It's got to be pre-renal, right? Renal artery stenosis. If you have a blockage in that renal artery, less blood's getting to the kidney. If less blood gets to the kidney, what's it going to start to release? Renin. What's that going to do to your blood pressure? It's going to rise it. So if someone is refractory to your medications, get a bilateral renal ultrasound and see how their kidneys are doing with the blood supply. You also, while you're there, check the adrenals, make sure there's no pheo. Check it all, find out why they're. We're going to go over another cause in a little bit of why they could have other reasons for blood pressure. So complaints, headache, palpitations, and perspiration are the main ones. And if you look over here, there's a little mnemonic for you. PHE, palpitations, headache, and episodic sweating. Okay, there's also other ones, pallor and orthostasis, but PHE, those first three are the main complaints they're going to have when they come and see you. Obviously, most common presenting feature is going to be high blood pressure because their blood pressure is going to be high because of all the catecholamines. Systolic BP can get as high as 300. What potentially can happen when that blood pressure spikes like that? Stroke, hemorrhage, you can burst those vessels. So that, again, same reasons we're so worried about blood pressure, same reasons here. That blood pressure spikes that high, you can burst those vessels. Complications, these are all complications with having uncontrolled blood pressure. Hypertensive retinopathy, nephropathies, MIs, edema, strokes, maternal morbidity, and fetal demise in pregnancy due to this pheos. Okay, so these are some complications with a pheo. Whenever you guys are clearing someone for surgery, one of the questions you want to ask is, have you ever had surgery before? Have you ever been given general anesthesia before? Because if I have, and I can't, obviously I'm still alive today, then I recovered okay from that surgery and I was able to handle the anesthesia. If someone says, no, I didn't do very well with anesthesia, there's usually going to be some sort of underlying cause for that. One of them, watch out for, is the pheo. That's it for the adrenal medulla. Just those pheos, spike in catecholamines, too much. So let's talk about the adrenal cortex, and we have hyperfunction, we have Cushing's, and this ectopic ACTH syndrome are a couple of the major ones. So Cushing's syndrome, hypercortisolism, they're the same thing. This Cushing was the guy who discovered it and got the name after himself. Okay, most common cause, again, excess ACTH from a pituitary gland tumor, therefore it's Cushing's disease because the problem is in the pituitary gland. Then it's Cushing's disease. If the problem, the source of their hypercortisolism is somewhere else, it's Cushing's syndrome. Okay, so an ectopic ACTH syndrome, non-pituitary tumor. Like I said, a lung oat cell tumor, some of them can start this whole thing up. And they produce ACTH or a biologically active ACTH-like peptide. And again, we have all this excess ACTH. Adrenal cortex doesn't know, is this the real one or the fake one? And it just starts making a ton of cortisol. Okay, so it causes adrenal hyperfunction. Hypersecretion of ACTH and cortisol is random and episodic, depending on when you had a flare-up. ACTH secretion is not suppressible by exogenous administration of glucocorticoids. So, if I gave you cortisol and you had a normal functioning pituitary gland, that cortisol that I gave you will go to the pituitary gland and shut down ACTH production. So if I did, we'll talk about this in a second, but basically what we're doing is we're testing to see how we can suppress different parts of this ACTH production. And so what we do is what's called a dexamethasone suppression test. Okay? What we do, there are 2 doses of dexamethasone that we give. We give a 4 milligram and an 8 milligram. This is the low, the 8 is the high. So in normal patients, no problems at all with the pituitary gland, you give them dexamethasone in low doses, and we get suppression of pituitary production of cortisol. Because those cells are receptive to cortisol, it knows we have too much and it shuts it down because we have a normal functioning pituitary gland and we're okay. If we suspect the problem with the ACTH is a pituitary adenoma, if we suspect the pituitary gland is secreting a ton of ACTH, when we give the dexamethasone in low doses, there's nothing happening. However, when you give this patient the high dose, the 8 milligram dose, then we get some suppression of cortisol because there are still some cells that are responsive to the cortisol and provide a negative feedback. So if the low does nothing but the high will suppress cortisol, it's a pituitary problem. That's where your source is. Now, if it's an ectopic source of cortisol or ACTH, those tumors in the lungs, whether you give them high or the low, there's no suppression of cortisol at all. No suppression because those oat cell tumors have no receptors for cortisol. They don't know when to shut off. They don't have the receptors. Only the pituitary and the hypothalamus have the receptors for cortisol, not these. So they just keep producing ACTH all day, every day, because they're a tumor, that's all they're going to do. So there's no suppression because they have no receptors for cortisol. So cortisol never drops. So if I gave you a question on your test, I said, you suspect the patient with Cushing's, you give a dexamethasone suppression test. Low dose, nothing happened. High dose, there was suppression. Where's your diagnosis? Pituitary. Because they're still responsive at high doses to that stuff. Any questions about Cushing as far as the diagnosis of it and everything? We already went through the symptoms before. Next, hyperaldosteronism. Now we have too much aldosterone. Okay, a primary hyperaldosteronism is a problem with the adrenal gland itself, and that's called Conn's syndrome. Okay, so whenever you hear the word Conn's syndrome, think hyperaldosteronism. Too much aldosterone. So, let's look at this graph here. This is the tumor right there. And that tumor is just secreting aldosterone. That's all it does. It's an aldosteronoma, and it just secretes aldosterone like crazy. So we have increased aldosterone, still going to have its effects. Sodium retention, potassium loss. So what's going to happen to our blood volume? Going to go up. Because blood volume is going up, renin's going to go down. We don't need it. And angiotensin is also going to go down. But what do they still are going to present with? What does aldosterone do? What's the purpose of, what does aldosterone do? Secrete potassium and reabsorb sodium and water. If I'm reabsorbing sodium and water a lot because aldosterone is secreting too much, what's going to happen to my blood volume? Increase. My blood volume goes up. What happens to my pressure? Also goes up. Hyperaldosteronism is another cause for secondary high blood pressure. You give these people medicine, it's not going to do much because they have this hyperaldosteronoma due to this tumor, too much aldosterone. Okay, so that's Conn's syndrome. Again, unregulated secretion of aldosterone. Other cause, bilateral adrenal hyperplasia. Okay, the adrenal itself, just the tissue grows too much. Hyperplasia, too much growth of a tissue. all that tissue, all that is going to secrete aldosterone. It's thicker. Okay? Most common, potentially curable, and treatable cause of hypertension is hyperaldosteronism. Okay, you'll go through a lot of this stuff with Dr. Ovalle when cardio starts up next week with blood pressure. This is going to be one of them. So, what's going on with primary hyperaldosteronism? We have an abnormal zona glomerulosa, so we produce too much aldosterone. Chronic aldosterone excess gives expansion of their extracellular fluid volume and plasma volume, so your blood pressure goes up. Stretch receptors in your juxtaglomerular apparatus, macula densa, suppress production, so you're going to see a decrease in plasma renin activity. Why I keep bringing this up is because we're going to talk about in a second secondary hyperaldosteronism. The stimulus of what causes it are different, and your values of renin are going to be different as well, depending on the cause. Okay, so is everyone good about primary? The primary insult is too much aldosterone coming from the adrenal cortex, either due to hyperplasia or a tumor. And because of that, our pressure volume is still high, renin is low. Now let's talk about secondary hyperaldosteronism. This is a problem outside the adrenal gland. So primary aldosteronoma or bilateral adrenal hyperplasia, but secondary hyperaldosteronism is something else. We get high renin output. Okay, that's why I mentioned renin so much on the primary being low, because in secondary, the renin is high. Okay, what causes high renin to go out? Obviously, it's got to be a lack of blood supply to the kidneys, right? That's what causes renin, blood supply. So look at these answers. Renal ischemia, renal artery stenosis, lack of blood supply going to the kidney, renin goes up. It's going to trick it. Decreased intravascular volume. Okay? Basically, hypovolemia. Less blood going to the kidney, less stimulus, macula densa goes crazy, renin goes nuts. Sodium wasting disorders. If you have a sodium wasting disorder, where's all the sodium going to go? Urine or stay in the blood? Urine. If all that sodium is going into the urine, what's also going to go along with it? Water. And if water is leaving the blood volume, what happens to your blood pressure? Drops. And there you go. Hyperplasia of the juxtaglomerular apparatus. This has to do with the macula densa. And any renin-secreting tumors. So, overall, secondary hyperaldosteronism is due to RAS hyperactivity. Something is causing this renin to go up, which will then cause aldosterone to go up, right? Because renin, the whole cascade. Renin, angiotensin 1, angiotensin 2, to aldosterone. So if you're having a problem leading into the kidneys to cause your renin to rise, then later on, aldosterone is going to rise, and that's going to cause further sodium retention and increased potassium loss. Okay? And I think I have a picture showing the two. So, pathophysiology of secondary. Low blood volume is the stimulus for secondary hyperaldosteronism. What's the stimulus for primary? Well, hyperplasia then causes what? Increased, not renin. Aldosterone starts the entire cascade. High aldosterone starts the problem with primary. Aldosterone secreting tumor is just dumping aldosterone into the system. That's primary. And because aldosterone's already high, because artificially from a tumor, there's no reason for renin to come out because we already have the aldosterone. We don't need the renin, so renin drops. In secondary, the cause is the increased renin due to low volume. Low volume is the stimulus for secondary hyperaldosteronism because low volume due to any of these causes, the result is less blood going into the kidneys. The kidneys suspect that, thinking that the body has low volume, so it's going to dump renin out. The end result of all that renin is going to be high aldosterone. So the end result for both of them is going to be high aldosterone. The question is that you guys got to know is what caused that high aldosterone? Primary, aldosterone tumor, adrenal hyperplasia. Secondary, anything causing low blood volume going to the kidney. That's why these hyperaldosteronomas, or the hyperaldosteronism, just primary or secondary, you can treat that. It's curable for blood pressure treatment. They don't need to be on blood pressure medication after this because you fixed the problem. So renin comes from the kidney, aldosterone goes up, and in disease states like renal artery stenosis, the kidney still never perfuses well because there's a blockage in that renal artery. So no matter how high that blood pressure goes, that kidney is never going to be perfused well because there's a blockage there. So that renin is going to keep going up and up and up and staying high, giving you constant blood pressure. Another thing you can do for these patients, 24-hour blood pressure cuff. What is your normal response to your blood pressure when you go to bed at night and go to sleep and you're sleeping all night? It goes down, okay? In these patients, it doesn't go down. Their blood pressure stays high all night. And that blood pressure cuff stays on their arm when they sleep at night, and like every hour it goes off and it measures their blood pressure and records it. And if it stays high all night, start looking at secondary causes for high blood pressure. And this is one of them. So again, the end result, the effect of excess aldosterone, whether it's primary or secondary, they're going to have high aldosterone. So we know we have high sodium and water retention, secretion of potassium and hydrogen into the urine. So the big sign is going to be hypertension when they come in to see you. Okay. Now, the big thing here is that obviously we're going to have high blood pressure, more volume in the system. We're going to stretch atria, so ANP is going to come out as well to try and help with this fluid overload. Okay, creates an escape phenomenon. Some excess salt can be excreted into the urine, so they don't really become edematous, because you can, with this ANP, you can get enough of that salt out so they don't become edematous and really fluid overloaded. But the end result for hyperaldosteronism is going to be metabolic alkalosis. Also, all this potassium loss, hypokalemia, muscle weakness, paresthesias, tetany. Okay, it's also interesting to note that when you lose potassium, ADH doesn't work as well in the kidneys anymore. So you start getting nocturia and polyuria as well. So when you go to bed at night, the kidneys work a little bit better because there's no gravity, you're laying down, blood can perfuse easier. But ADH is still stimulating thirst, so you're still drinking. Polydips you like crazy because of all this, the ADH. So overall, hypertensive, hypokalemic, and alkalotic is what happens when the blood tests when you do on these patients. So this is a very good slide as it talks about your primary and your secondary. The one that's in blue is the initiating event, increased aldosterone or low blood volume. And by now, this graph hopefully should make sense, or when you guys start to study, you should be able to figure out this graph and why it is the way that it is. Start with the initiating insult. Primary, high aldosterone. Secondary, high renin due to low volume of blood. Okay. That's it on hyperaldosteronism. Now let's talk about hyperfunction of our androgens. This is going to be congenital adrenal hyperplasia, chiefly regulated by ACTH secretion, masculinizing, and anabolic effects. Normally, we don't make a lot of androgens this way, and the majority of all those precursors go towards cortisol and aldosterone. But if you have certain problems, some enzyme deficiencies, you can't make cortisol and aldosterone, so all these products all going to be turning into androgens. And you have excess androgens now, and that causes the masculinizing and these anabolic effects. Okay? DHEA and DHEAS metabolize to your testosterone and dihydrotestosterone and estrogen. Obviously, your testosterone is most important, most potent one. 1 in 10,000 to 18,000 children are born with congenital adrenal hyperplasia, CAH. Can occur both in males and females. In females, externally can look like males when they have too much androgens going on. The internal sex organs are fine, they don't change, just external stuff. Males will look the same, but they'll enter puberty early. It's called precocious puberty. They enter puberty early, 8, 9 years old. So again, here's what happens. Excessive secretion in androgens in females, hirsutism, which is what that is, acne, deepening of the voice, baldness, just your secondary sex characteristics for males. 5 major conditions that are associated with androgen excess. Here's your PCOS I mentioned before, polycystic ovarian syndrome. Androgen-producing tumors of the ovaries or adrenals. Okay, they just produce a lot of those androgens. A late onset congenital adrenal hyperplasia, idiopathic hirsutism, and precocious puberty. Okay, these are conditions with high androgens. So, classic congenital adrenal hyperplasia, most commonly due to deficiency in this 21-alpha hydroxylase, cortisol deficiency, and low aldosterone if you have 21-alpha hydroxylase. You're still making androgens because you don't need that enzyme to make androgens. So without cortisol, there's failure of that negative feedback. Because there's negative feedback failure, we get very high CRH and ACTH from the anterior pituitary. Deficiency in production of cortisol and aldosterone with shunting of those precursors to form the androgens. We still get high ACTH with these patients. They get ambiguous genitalia in female neonates if it happens during development. So here is our 21-alpha hydroxylase. You see that it's needed to convert progesterone to deoxycorticosteroid. If you don't have this 21-alpha hydroxylase, this never happens, and you don't make aldosterone. On the cortisol side, 21-alpha hydroxylase helps convert the 17 to 11. You don't need to know all those specific things. Understand the use of 21-alpha hydroxylase and why it's important. It's an enzyme needed for the conversion of the products. If you don't convert them, progesterone goes straight. This is the method that's going to happen. Because you can't go down the first road. You can't go down the second road because you don't have the enzyme. So all the progesterone gets converted to 17-hydroxyprogesterone, and then all that gets converted later on down the road into all the androgens. Normally, everything goes to aldosterone and cortisol, so we don't have very much androgen production in the adrenals. Okay? But when you have an absolute 21-alpha hydroxylase deficiency, this is the one that occurs all the time. So this picture, when you're looking at this picture, it's showing you the feedbacks. The thickness of the arrows designates how much is being dumped. So if you look at untreated congenital adrenal hyperplasia, look how thick that arrow is compared to that one. Look how thick that arrow is. And finally, look at the androgen. It's a very, very wide arrow because in untreated CAH, everything goes towards the androgens. And once you treat it, you give the person cortisol. If you have this condition, you're on cortisol for life. And if you don't take it, you can have some serious problems. Now let's talk about hypofunction. This is lack of. Okay. Addison's disease is lack of cortisol. Adrenocortical insufficiency. Mainly it's cortisol. You get some aldosterone in there as well. Results in deficiency of cortisol, aldosterone, and the androgenic steroids in women because Men have testes that make the testosterone. In women, they need a little bit more help with the androgens. Etiology, primary hypofunction, you just destroy or dysfunction of the adrenal cortex. Usually a congenital problem. Secondary issues, either deficient pituitary production of ACTH. We have a problem with our pituitary gland. It's not producing any ACTH. Therefore, you're not going to have any cortisol. Or a problem with the hypothalamus. Hypothalamus may not be releasing corticotropin-releasing hormone. Therefore, everything downstream doesn't work because the first thing never started. So Addison's disease is primary adrenocortical insufficiency. It is autoimmune in nature. TB also is a culprit in the formation and the starting of Addison's disease. Very rare, a little bit more females than males, and usually starts around the 3rd or 5th decade. So autoimmune destruction is believed to be the start of it. Generation of these anti-adrenal antibodies. Okay, so they're anti-adrenal. They're going to attack the adrenal glands, causing the issues to happen. There's 2 types of antibodies. There's adrenal cortex antibodies, ACA, and antibodies to the 21-hydroxylase enzyme. Here's that 21-hydroxylase enzyme again. Highly specific for Addison's disease. You're not going to make any aldosterone or cortisol because you don't have the enzyme. Okay? So our basal glucocorticoid secretion is not normal, but the other problem, or secretion is normal, but it does not increase in response to stress or surgery. When you guys have a stressful environment, your cortisol rises to help you deal with that stress period. In these patients, they can't make cortisol, so when they undergo these stressful periods, they don't have the cortisol there to help with them. And you'll see what happens when we get to these problems. They can even go to a coma and die without having cortisol, and sometimes the aldosterone as well. So trauma and infection can make these acute adrenal crises worse. They usually wear a bracelet, these patients, that they have acute adrenal crisis or Addison's disease. So if they're ever like stuporous or almost in a coma, and they're found somewhere, someone can see their band and be like, oh, this guy needs cortisol, let's give him some cortisol, get him in the hospital. So with further loss of cortical tissue, we lose our glucocorticoids and our mineralocorticoids, become deficient, and we get signs and symptoms of adrenal insufficiency. Now, we don't have any cortisol that we're making, so is there any negative feedback on the pituitary or hypothalamus? No negative feedback. So what's going to happen to ACTH? It's going to go up. Nothing is telling the ACTH to stop because there's no cortisol anymore. So ACTH goes crazy. Now, the problem with that, it causes hyperpigmentation because POMC is the precursor, and that makes ACTH and MSH. So if I need a lot of ACTH because my adrenal cortex isn't working, it's not responsive, I need more ACTH to stimulate the adrenal cortex to do something. So POMC has to increase. You don't need to know what it means. It's pro-opiomelanocortin. But just know POMC will dissociate into ACTH and MSH. We need the ACTH because we're trying to stimulate the adrenal glands. The MSH kind of comes along as a consequence. So one of the signs that you'll see with Addison's disease is hyperpigmentation. Usually in skin creases, the pressure points, knuckles, you'll see pigmentation. Your palmar creases will get darker. Your buccal mucosa will get darker. You look like you have a tan all the time because of this excess MSH that's being secreted in your body all the time. You also get impaired gluconeogenesis, so they get hypoglycemia. No cortisol, no gluconeogenesis. So we're going to be low in sugar. Fasting can cause severe and potentially fatal hypoglycemia, so they got to eat. The aldosterone deficiency side, we're going to have problems with renal loss of sodium and water. So no aldosterone, hypovolemia. Okay, nothing can support their blood pressure. They're going to have low blood pressure. result in prerenal azotemia. What's azotemia? Increased BUN. And hypotension. The water is leaving the blood, it's going into the urine, and we're peeing it out. Salt craving can occur in about 20% of patients, and obviously hyponatremia because we're losing all the sodium and water into the urine. It is associated with some autoantibodies to other tissue antigens as well. So there's some crosstalk between like all the autoimmune diseases kind of sometimes will affect each other. When we get to endo in the winter, we're going to talk about multiple endocrine neoplasias, and there are different combinations of different types of like Addison's disease or hypothyroidism or other things, all related to these autoantibodies, this autoimmune stuff. But don't go crazy knowing these things for now. Signs and symptoms: fatigue, weakness, anorexia, nausea, vomiting, diarrhea, abdominal cramps is one of the biggest complaints they'll come in with, are these stomach GI distress. You won't know these until you start looking at your blood results yet, but they will have that on labs. Hyponatremia makes sense because there's no aldosterone to bring it back into the blood. What do you think is going to happen to the potassium? Increase. You get hyperkalemia because aldosterone's not there. Sodium's going to build up in the blood. And your hyperpigmentation of the skin. So this is what it looks like, the different hyperpigmentations. And there's your little slide on Addison's for review. So this is the major problem, these acute adrenal crises, also known as an Addisonian crisis. Okay, it's a medical emergency. Can occur in cases of undiagnosed ACTH deficiency, people who are receiving corticosteroids who don't increase their dose. So these patients in an Addisonian crisis are already on cortisol. Every day they take it. However, they have to be told if they have a big exam tomorrow morning, double their dose. They're going for surgery, double their dose. If they get sick, double their dose because they need the extra cortisol during that stressful period. Here, they can't do that. So if they don't increase their dose, they will be in a hypocortisol environment or abrupt withdrawal of corticosteroids. What do we do for those dose packs? Taper off. You give big doses at first, and then you slowly back off on the endogenous cortisol. Why do we taper it off? We want your own body's negative feedback to kick in again. If you don't, there's no negative feedback anymore. Once you stop those pills, you can cause problems. So these are all things that can precipitate an Addisonian crisis. So they wear these bracelets to help identify themselves when they go to the hospital. Okay, this is the last little bit here and we're done with this lecture. So let's start here. Adrenal glands don't function. We have two pathways. The first pathway, cortisol. The second pathway, aldosterone. So when you don't have cortisol, liver function starts to decrease. We're not making any more glucose. Low sugar leading to extremely low sugar, which can cause brain coma and death. Severe hypoglycemia will get very obtunded, potentially into a coma. Now, lack of cortisol, also stomach digestive enzymes decrease. Remember we said cortisol during periods of high stress, your stomach acids go up. Now we don't have the cortisol. So stomach acids drop a little bit. Because of that, you may get some vomiting, diarrhea, cramps. If you're vomiting, what are you losing? Water. Low fluid volume. Hypovolemia can lead to shock, and that goes to brain death or coma. That's why they need to be on cortisol. This is why they need to increase their cortisol during periods of stress, so you don't have this cascade occurring. Now let's talk about aldosterone. What are the effects of aldosterone? On the kidney, water and sodium loss. Well, sodium loss can cause heart irregularities, output changes. Remember cardiac output? Volume drops, cardiac output's going to drop as well. Cardiac output drops, low blood pressure, shock, death. When the kidneys, with all that water and sodium loss, also leads to low fluid volume, shock, brain death, and so forth. This is the cascade. You got to know this one. Understand why it's important that we need cortisol and aldosterone during these periods of stress. Now, if they have an Addisonian crisis, of the two, which one do you think is more important to replace faster? Cortisol. The aldosterone doesn't need to be replaced as fast, but the cortisol, definitely you need to replace it. So there's your review, and you guys can look at this. Let's take a break, come back at 2:45. We'll do the last one.
The last bit that we just learned, if you gave those patients cortisol after, like, let's say unexpected stress happens for them, like unexpectedly, would the cortisol like still kick in enough time to help them?
No, that's why we tell people to pre-medicate. Like if you know you're going for surgery, you know you have a test, or you know this, do it beforehand. But like if you're getting sick, depending on how sick you are, if it's just you have a cold at home, you can just take an extra pill.
Or like not even serious, like if they came with bad news, like unexpected bad news.
I don't know about that if emotional stress causes that big of a problem with cortisol. I don't know about emotional stress, but I know about the other things.
Like exams, I don't know.
Yeah, I don't know if exams really do, but like when it's a transient stress. If you're sick or inflammation going on, it's more. It'll be there for a couple of days. Yeah, so it's just they take it every day, but when they feel the stress, they take more.
Interesting.